thank you. At the outset, I'd also like to thank Dr. Palipu Gopal, Srinivas and Venkat for inviting me to give today's talk on cutting the duration of antibiotic therapy. And I also like to thank Dr. Ramraj Gopalan for allowing me to take his time because I have a flight to catch. So that's the reason. So I've been asked to talk about into the antibiotic sessions on cutting the duration of therapy of antibiotic, how it should be cut short. All of us are using antibiotics left, right and center, and even for sometimes we see that there is a misuse of antibiotics, there is overuse of antibiotics. We often sometimes see that certain prescriptions, unfortunately even for viral infections, antibiotics have been considered and also been used. There are different indications, different ways, whys, ifs, not, but, whatever, why antibiotics are being used. But really speaking, antibiotics should be used at the right time, in the right duration, for the right dosing, and then only you get good results. And we'll try to see how we'll try to reduce, and not giving antibiotics for a long period of time really is still more beneficial. We have got the antimicrobial stewardship programs which are running, which are all worldwide. Each and every conference, each and every meeting has got an antibiotic stewardship program which is running. Every hospital has got antibiotic policies. Basically, these antibiotic stewardships are basically done to avoid the misuse or the overuse of antibiotics. And again, misuse or overuse of antibiotics can again predispose for development of new multiple drug development resistance of antibiotics. And this also helps to educate a lot of consultants apart from the intensivists. Intensivists are the ones who are mainly using antibiotics very judiciously, but at the same time, you must also educate the other consultants from other specialties who are also having patients who have been admitted to the intensive care units. And as a result of which, that's very important. And this antibiotic stewardship plays a very important role because it also decreases the unnecessary use of antibiotics, it reduces the antibiotic pressure, and it also helps us to use and select the right choice of antibiotic and give it by the right route at the right time and the right dose. Because studies have also shown that it helps, if it's done this way, then the morbidity as well as the mortality rate definitely goes down. Certain indications are there, you need to give prolonged antibiotic therapy. Really speaking, there are only a few where you need to give it over a period of 4 weeks or 6 weeks. Like infective endocarditis or osteomyelitis, yes, basically because the penetration or the drug concentration or the tissue penetration is quite slow, and therefore you need to give it over a period of time. Fungal infections are there, you again need to continue antifungal for a period of at least a long period of time, and they say 2 weeks after the last culture report has come negative. That is a time where you really need to continue antifungal therapies. And one is Legionella pneumonia, where you again need to give a prolonged antibiotic therapy, and this again till the culture becomes negative, you also need to continue that. So as I said, that's equally important, and timing plays a very important role. There is a big association, as I said, and Dr. Anand Kumar's papers, which have also been studied by all of us, and we have also seen that if you use the right choice of antibiotic, preferably within the first 1 hour, which is now been included into the surviving sepsis guideline, it also helps to reduce the morbidity as well as the mortality. Mind you, not just giving the antibiotic is important, you have to give antibiotic in the right dose and then in the right combination. That's very important in order to reduce the morbidity as well as the mortality. Now, what are the different questions what we really have into our daily practice? Is 2 weeks or longer therapy is really justified? Like whether we need to continue antibiotic for 2 weeks. We have got certain people who say no, antibiotic should be given for 7 days. Some people say give it for 8 days. I don't understand what's the difference between 7 days or 8 days. Some people say give it for 10 days. But every person, so everywhere you see variations. But studies have also shown that yes, giving antibiotic for a prolonged period of time is not shown to have any beneficial effect. In fact, and at the same time, in certain studies have also shown it has done more amount of harm than rather than doing good. There is a study which was again done by ventilatory associated pneumonia, and there is no one size which really fits all, that you cannot have an approach which is there. This study was published in 2001. The VAP resolution of the clinical parameters with adequate antibiotic therapy occurs after first 6 days of therapy, and they thought that PO2, FiO2 was a significant marker, and continuing antibiotic therapy beyond this was quite more delirious. We definitely see a clinical improvement is much more better. So clinical examination of patient is equally very much important, just rather than following the x-rays, because we know that sometimes radiological resolution for complete resolution to occur can again take approximately a couple of weeks to occur till a complete resolution occurs of the patch. But if you find that the PF ratios are better, the counts are getting down, the color of the sputum has changed, there is no fever, there is no breathlessness, definitely there is no point in continuing antibiotic beyond say 7 days, and or even if you continue beyond 7 days, they have found bad results which is there. This again study was again showed 7 days to 8 days, and they continued and controlled it with about 15 days of therapy, and they found that there is no difference in the morbidity, mortality, or there is a recurrence pneumonia which was there, or there was a treatment failure. So this again justified that a 7-day therapy, once the clinical signs of improvement are there, and there is element, as I said, a PF ratio which is better, counts have reduced better, and therefore even the Infectious Disease Society as well as the American Thoracic Society now recommend a 7-day course of antimicrobial therapy for ventilator associated pneumonias. But mind you, it has to be backed up with good amount of culture, sensitivity, with good MIC values, and you need to use antibiotic in the right dose and in the right combinations. That's very, very important. Should biomarkers be used to stop antibiotic therapy in all critically ill patients? Yes, we have been using initially till a few years ago, we have been using CRPs, we have been using the total counts as one of the markers which are there. Now we have got other markers which are available in the form of CRP, we also got the interleukin levels, we have got the procalcitonin levels. But in this area, the clinical signs of infections which are there are sometimes very difficult to interpret. The cultures sometimes come only positive in only 10% to 15% of the population, and therefore sometimes we need to rely upon these other investigations to help us or find out whether there is element of infections. Sometimes the pulmonary infection score or the CPIP score is not exactly not to be sufficient, and we don't know exactly what the diagnosis. The culture still comes out to be negative, the person still has running fever which is there, and that is the time when we get the thoughts of drug fever in our mind, when the patient is admitted to the intensive care unit for a long period of time, and we are using left, right and center, and we just keep, though the cultures are coming negative, and we keep on jungling from one combination to another combination because the patient is just running fever and the counts are on the higher side when other markers are negative. And the markers which we use is CRP. It's quite cheap. It is easily done into any hospital which is there, as compared to a procalcitonin level which is quite costly to be done, which costs approximately 1500 rupees which should be done, and a CRP level. Which is just costing about 100 rupees to be done. Yes, it's an excellent marker. In case if you don't have a procalcitonin level in your unit, you can easily do it with the help of a CRP level, which will tell you, yes, it's an inflammatory marker, there is element of infection, that is sufficient to say that. And procalcitonin, the ProRata trial which has shown, they also gave antibiotics with the help of a procalcitonin driven algorithm, and they found that it was non-inferior to standard care. Yes, it is just like a marker of inflammation. It is useful. It also significantly helps to reduce the antibiotic exposure. There have been certain places, and a serial measurement of procalcitonin is much more useful as just compared to doing a one level of procalcitonin. And if you really want to do procalcitonin, yes, definitely on admission, or if you think of sepsis, that is the time, the best way is to do a procalcitonin, because that will act as a benchmark of your procalcitonin values. And later on, if the patient is going into infection or sepsis, if the procalcitonin levels are definitely increasing, they say that yes, it is definitely element of infection, and they tell you whether, and this will help you to guide further. Other studies which are there, they have also given the procalcitonin guidance was not associated with increased mortality. So it was not exactly beneficial as far as just monitoring of the antibiotic roles. And a total antibiotic exposure was significantly lower. And we have got other tests, as I said, it's sometimes advantageous. One, because it is only specific for bacterial infections. It is rapidly rise occurs within the first 6 hours, and the half-life of procalcitonin is just about 24 hours. And there is a rapid decline which occurs with infection or the immune control of the infection. So a marker is much more better, or the progression or monitoring of the serial procalcitonin levels are much more better. It has got excellent correlation with the severity of infection, and the production is not impaired by neutropenia or again by other immunosuppressive states which are important. The other markers are interleukin 6 levels, and they go hand in hand parallel with the CRP levels or the interleukin 8 levels, and both higher levels on day 1 hospitalization, they have again suggested that there is a prediction of treatment failure. But mind you, these are all theoretical. Each and every hospital do not have the facilities to monitor. These are usually done as a part of research kind of institution, but mainly for practical aspect, we are only doing the CRPs and the procalcitonin in majority of the hospitals. So biomarkers do have a role as far as to give amount certain guide for antibiotic duration. If you find that after 7 days or after giving antibiotic, if the procal or the markers are, and there is clinical improvement, definitely you can de-escalate or stop antibiotics. The interpretation should be done very, very cautiously. As I said, in the clinical, always a clinical examination of the patient is very important, and it should be always have a clinical correlation and not just depend upon the lab reports which are coming in. They also helps us to guide, especially in difficult scenarios. As I said, it's a case which is admitted for a long period of time. The patient has got multiple cultures which have now initially come positive. You have used different combinations and sets of antibiotics, and now the patient still running fevers, and you don't have cultures which are coming in and so positive. Then sometimes if the procal is also normal, you can also think of drug fever and one of the causes for it, and then it also helps you to de-escalate it. And it can never substitute, as I said, the clinician's most important experience. That's very important, should be taken into consideration. And would longer antibiotic reduce the recurrences? This study was again done by Dr. Shastre, and 2 antibiotic regimes were given again in VAP for 8 days and 15 days. And patient who had received 8 days of antibiotics, recurrent pulmonary infections with MDR pathogens emerged significantly less frequently than those where in the group where a longer antibiotic therapy was given. So mind you, like even a shorter course is much more beneficial. You don't need to continue it for a long period of time, but this definitely has to be taken with the clinical judgment of the patient. And sometimes using it for a long period of harm, it does more harm than doing good. It not only increases the economic burden onto the patient, but the length of hospital stay also goes on increasing, because the cost factor, because of antibiotics, they are not very cheap, and definitely that's also equally important. In Pseudomonas aeruginosa, yes, this study was again done by Marine Koloff, and he again found that in those patients where there was a confirmed microbiologically confirmed VAP, he just gave a 7 days of therapy, and this had a non-significant higher rates of clinical failure as compared to a 10-day therapy. So all the studies which have shown, they have said a 7-day or day therapy is much more beneficial. There's no need to continue it for a longer period of time, and this has definitely reduced this, helped us to de-escalate antibiotic use judiciously also. And does it help to make in the clinical cure as well as sterilization techniques? Now, we have seen that the normal endotracheal tube or the normal oral cavities, or there are certain commensals which are there. Certain commensals also, sometimes we have seen that there is a misuse of antibiotics for commensals. Simple just because, and sometimes we are using antibiotics whenever just a central line has been put, or just because a Foley's catheter has been put. There is no indication or guideline which says that just because the patient has a line or an endotracheal tube or a Foley's catheter, you should have antibiotics to be given. And the colonization and infection definitely needs to be ruled out. And endotracheal colonization is very, very common as equivalent to Foley's catheter colonization, and it is not equivalent to infection. Like especially if you have a colonization coming up, it does not mean that there is infection. And bacterial eradication which occurs from the aspirates is a poor marker for clinical response. And appropriate antimicrobial therapy can rapidly eradicate the colonization by Streptococcus pneumoniae, influenza, and Staphylococcus aureus, but it does not eradicate, more importantly, the infections or the colonization done by means of Enterobacter or by Pseudomonas which is there. Now, situations where you have got clinical overlaps or with poor clinical responses, you have got unusual pathogen or unusual bacteria which has been there, especially like a virus or a fungal infections where you require, as I said, a prolonged therapy till 2 weeks after the cultures have become negative. Inadequate antimicrobial therapy has been used, or improper antibiotic combinations have been used, then you get a poor clinical response which is there. A long diagnosis is there. Sometimes just for pulmonary embolism you have been using diagnosis, you have been using antibiotics, or there is atelectasis and you think it's a consolidation and therefore antibiotics have been again started. ARDS or alveolar hemorrhage and neoplasia, these again a wrong diagnosis where sometimes wrong antibiotics are again used. Therefore, there is a misuse and you sometimes tend to. So, you have to reach a proper diagnosis before judiciously use, and therefore at the same time this will also help to cut down the duration of therapy of antibiotics. Yes, complications are there where there is empyema or lung abscess, but at the same time if there is empyema, proper source control also needs to be done by putting an IC by intercostal drain so as to remove the pus, or if there are pus pockets which are there, if it requires thoracoscopy, might as well do it and have a proper source control, just because just continuing antibiotics for a prolonged period of time is not going to be beneficial unless and until the source control which is also being done. And mind you, as I said, a drug fever which should always be kept in mind, especially when antibiotics have been used for a long period. So mind you, you have to be very cautious in use. There is no benefit which is seen over the use of antibiotics over and over above beyond 7 days or 8 days. Just because the patient is running fever, the antibiotics are continued for 2 weeks or 3 weeks. In fact, it does more harm than it does for good. Now in Enterobacter, you have got resistance, and tracheal colonization is not a marker for treatment success. And in prolonged therapy, a resistant pathogen frequently occurs during the second week of the therapy. So mind you, you have to be very, very cautious. You have to use it very judiciously, and you have to de-escalate. You have to respect the cultures which are coming in, and especially if you are using, you have to at the same time de-escalate and use it only for a short period of time. And is antibiotic therapy an innocent and always a beneficial therapy, particularly if it is prolonged? This study was again done by Dr. Singh, and most antibiotics which were used in ICU in fact occurs in whom pulmonary infiltrates are there, and just because they are infiltrates, it does not account for infection or pneumonia, and it could be, as I said, could be because of pulmonary edema, or it also could be because of atelectasis. You have seen a left ventricular failure just because there is pulmonary edema or infiltrates. What we see sometimes is being misinterpreted as ARDS, and sometimes antibiotics are being started rather than properly optimizing the anti-failure or anti-diuretic use. And antibiotics sometimes were invariably continued for average of about 10 days regardless of the pneumonia. No diagnosis was tried to reach, and therefore again prolonged therapy was being given, and this antibiotic course was prolonged and was associated with a higher mortality and more amount of development of MDR pathogens. Over a period of time, if we don't de-escalate, if we don't use it judiciously for a short or a limited number of time till we get a clinical response, we don't have much antibiotics in our basket, and which are going to be available into the near future. We already have got almost a full basket, and therefore we will be developing more amount of MDR pathogens which are coming up, and which will increase the resistance, at the same time increase the cost, morbidity, at the same time mortality. And what strategies do we have to make in decisions to discontinue antibiotic therapy? Yes, this was a flow chart what I found out. Yes, culture results have to be taken. A good clinical response and a good clinical examination is equally important. You have to give importance to temperature, at the same time the X-ray chest, the oxygenation, saturation, the hemodynamics, as well as the organ perfusions. If clinical improvement is there after about 48 to 72 hours, yes, if the cultures are negative, yes, you can definitely stop antibiotics at day 7. Or if the cultures are still positive, and if other cultures, like for example you are using multiple cultures, and if antifungal turns out to be positive, then you can definitely de-escalate certain. So if you have added anti-staphylococcal also, you can de-escalate anti-staphylococcal antibiotics and then just continue with antifungal and treat the patients for about 7 days. Yes, mind you, but if it's antifungal, you have to be cautious. You have to give antibiotics for, this is one area where prolonged use is required, for 2 weeks after the culture turns out to be negative. And if you have found that there is no responses which are there, cultures are still negative, you have to find out whether you are dealing with a proper diagnosis. Is there any other complications what are there, or you should adjust the antimicrobials and search for the agents, other agents which are equally important, which will have a good penetration and drug levels, which definitely how to select depending upon the PKPD, definitely sir is going to cover it up onto the next stop. So the appropriate use also depends upon the local antimicrobial resistance or the profile of your unit of your hospital, whether the patient is also being shifted from another unit to your hospital. And it is not a straightforward. You should definitely spend time. You should have a good correlation with or discussion with your microbiologist, and you should definitely, if the microbiologist is not meeting you as an intensivist, I preferably feel that you discuss it directly with the microbiologist. What is the current spectrum of the flora or the resistance sensitivity pattern which is going up in your hospital or in a unit. And majority of the trials which have been done into these patients have to be done into real critically ill patients rather than just a label of critically ill patients, when exactly how these studies should be done. And the interpretation of these clinical situation must be taken very, very important, and you should study these results particularly into critically ill patients, and then only depending upon the culture and depending upon these values of other inflammatory markers, it will help you to de-escalate antibiotics. So antibiotic resistance basically is a serious problem. Using it for a short period of time is not harmful. In fact, using it for a long period of time can have deleterious effects such as development of more of MDR pathogens. It increases the cost, increases the economic burden, and the best way to decrease antibiotic use is to stop it whenever they are not required, whenever you find that there is clinical improvement and the cultures are really negative, and you do not start antibiotics first of all whenever they are not indicated. And most importantly, remember, there are multiple ways to identify the appropriate length. Although no therapy is perfect, there are only few indications where you require for a prolonged therapy of time, and mind you, there is no one size which really fits all. Thank you very much.
Yeah. Thank you, sir. And any questions? Sir is leaving, so one or two questions you will take. Yeah, sir. Some questions.
Being in sepsis. My second question is, what is the evidence of using serum procalcitonin in a patient with neutropenic sepsis who had recrudescent fever again, where situation we don't know whether it is a bacterial one or a fungal one, we don't know, because the patient is again having a fever. Which and how to choose?
See, first, procalcitonin is just one inflammatory marker. In case whenever it is increased, definitely a serial increment of procalcitonin levels are much more better to be interpreted. One, it specifically rises only more in favor of bacterial infections rather than in fungal infections. So even in febrile neutropenia, yes, but in febrile neutropenia, if you really consider the procalcitonin levels are on the higher side, if the counts are on the lower side, and as I said, it is not, procalcitonin levels are not altered by any immunocompetent methods or immunosuppressive drugs also.
So can we consider that as a
yes, it's a marker. Yes,
evidence of
yes, it's evidence of infection.
What is evidence of using procal as a mark of diagnosis so that we are not sure the patient might have sepsis or not?
See, for diagnosis of sepsis, I would give more importance for clinical examination. If the patient's blood pressure is on the lower side, if he's running fever, urine output is on the lower side, yes, definitely. And even then, procal, even if a CRP is positive, it's a marker of infection, it's a marker of inflammation. And if you find a procal level is on the higher side, yes, there is element of infection there.